Well, nice to have everyone on. We're glad you're here with us. Um, we'll just wait one more minute, but I just wanted to recognize the VC AAA to say thank you for helping organize these seminars. So if some of you are here for the first time or you've been on before, we have these monthly seminars hosted by the VC AAA. And it's just an opportunity to hear different experts in our county and in our field for issues ranging to help anyone who is aging, and that's really all of us. So, and we just have had an amazing experience having a lot of different organizations be on our panel. And so everything from the gerontologist to the conservatorship. So they've just been really great, really rich seminars, and they're brief, and we will have time for questions. So I'll go ahead and start. I am really excited to recognize Tree Paven. She is on our Home to Health Alliance and does an amazing job, which I will share more about that after. But this is, Tree is Livingston Memorial's President and Chief Executive Officer. She started her nursing career as an oncology nurse and joined Livingston Hospice 23 years ago. She held a supervisory role in Livingston's Home Health Division and moved to the Hospice Director of Patient Care Services, then was Vice President and Chief Operating Officer as the lead administrative oversight to Livingston's Home Health, Hospice, and Caregivers divisions. Ms. Paven took over the helm of the organization as CEO in June of 2021, and she brings over 28 years of nursing and leadership experience as she guides Livingston into the future. She cites her primary goal is to promote health, healing, and education in her community and herself. And she resides in Camarillo with her husband and 2 daughters. And I have worked with her the last couple years on our Home to Health Alliance, which she really spearheads. So we have better continuum of care from the services in our hospitals and that go on to when we need Livingston Memorial. So Tree, thank you for coming and being here with us today.
Oh, my pleasure.
And this is all you. You're going to go ahead and share your screen, I think, or is Ben going to share your screen? There we go.
I'll share.
Fabulous.
So does that look okay for you all there?
That sounds great. We can see it great.
Well, thank you, Maureen, and of course VC AAA for inviting me to participate today in this incredible series. Actually, this has been an opportunity for our community to really get a hold of some important information. And so again, thank you VC AAA for spearheading this really important initiative. And Maureen said in my bio that my personal goal, my professional goal is to promote health and healing and education in my community. And that's exactly what this incredible educational series on brain health and wellness does. So for 23 years, gosh, you said that sounded so long. I have worked for Livingston Memorial Visiting Nurse Association for 23 years. Livingston is a nonprofit home health organization serving Ventura County. We've been serving the county since 1947, a long time, way back when the first nurse actually jumped on a horse to go see the first patient. Can you believe it? So we provide home health, hospice, palliative care, and private duty caregiving to the community. So today we're going to be talking about in-home care, but I would really like to backtrack for a little commercial for VC AAA. There have already been 5 amazing presentations, and if you haven't seen them, I really encourage you to go back onto the VC AAA website, access them, view them. It's fantastic because you can pause whenever you need if you want to write down resources. They have been really excellent, and there's 5 more to go. We have today's, and then there's 5 more through the end of the year. So be sure if you haven't watched the recordings, you do so and sign up for those, the upcoming webinars. Okay, so today we're going to be talking about in-home care. The majority of in-home care is utilized by our older Americans. And let's talk a little bit about that. Aging in America. So the number of Americans age 65 and older is projected to nearly double by 2060. In 2030, Americans age 65 and older who will require nursing home care is going to rise by 50%. The demand for elder care is also driven by the steep rise in the number of Americans living with Alzheimer's disease. And that is a disease that has really started to touch almost every single person in some way or another. You know someone who has Alzheimer's or some form of dementia. Those numbers are going to double by 2050 to about 13.8 million people. So the bottom line is 70% of seniors will need some type of long-term care service. So what is that? Long-term care, it has care, but it could be for a short duration. It's really defined as care that involves a variety of services designed to meet the person's health or personal care needs during a short or long period of time. That could be a week, a few days, several years. The services help people live as independently and safely as possible when they can no longer perform everyday activities on their own. Again, I am sure everybody on this call is touched by somebody who needs some kind of additional care or help in their home. And the goal of this care at home is to help seniors age in place. Ultimately, we want to stay in our homes. Now, some people live in a private home. That's your home. Some are in a residential care facility, have been there for a while. You might be in an assisted living facility. Wherever you call home is where you want to age. It's where you want to stay. So how can we do that? We can do that through help from others and the different kinds of in-home care. So who needs long-term care? Well, I think almost all of us are going to need it at some point. Most Americans who are turning age 65 will need some kind of care in their home at some point in their lives. And by most Americans turning age 65, I'm talking about 70% of our seniors. But there are a few key factors that influence whether you will need additional care in your home. They're listed here. Primarily age, number one. The older you are, the more likely you're going to need some kind of care in your home. You know, we're living a lot longer than we used to. In the 1800s, life expectancy for both men and women was 41 years. But technology, medicine, health, lifestyle, over the years, things have changed. And now women are living on an average to 81 years and men 76. So things didn't quite even out. Women have taken a little step ahead, and that's here on this list as well. Gender, women outlive men by about 5 years on average. And that's not just here in the States, that's around the world. So as you live longer, the likelihood of you needing additional care goes up. And women will end up needing care longer than men, on average about 3 to 7 years of additional care help in the home, and men about 2.2 years on average. If you have a disability, you're more likely to need some assistance, some long-term care. And the older we live, the more likely you will have some kind of disability. 69% of people 90 and over have some sort of disability. A couple weeks ago, we celebrated the birthday of one of our patients. She turned 105 and was living in her own home still with additional care. And it was absolutely fantastic, and it's fantastic for her. But the longer we live, the more likely we're going to need some care. And your health status, of course, chronic illnesses like diabetes, high blood pressure, lung disease, COPD, those sorts of things increase your likelihood of needing additional care. And finally, your living arrangements. Do you live alone or do you live with someone? Those of us who live alone are more likely to need paid care or unpaid care. or assistance from a family member or a friend. Most of the care provided is actually from non-paid caregivers, our families and our friends. So if you need care in the home for either a short duration or a long-term duration, what are your choices? So today I'm going to explore with you 4 of those in-home care options: home health, palliative care, hospice care, and the most common, private duty caregiving. So what is home health? Home health is care for a homebound person who has a skilled medical need. That's bottom line definition. It's generally for a short period of time with a limited time frame. Palliative care is sort of this in between home health and hospice care. It's a newer term. It used to mean hospice care, but palliative care is a whole line of healthcare on the healthcare continuum that focuses on holistic care, reducing symptoms, promotion of support while somebody is going through a serious illness and is still getting aggressive care or treatment. Hospice care focuses on comfort and quality of life. That's for patients who have a terminal illness with 6 months or less to live, if the disease they have runs its expected course, and they're ready to just be comfortable and live their life for however long they have. Private duty caregiving, which is, again, I said the most common in-home care, and that is supportive non-medical care for those who need a little additional help in the home. And we'll go into a little bit more detail about each one of these as we move along. So first, let's talk about home health, palliative care, and hospice care. So for all 3 of these, the patients can be cared for wherever they call home. Now, that could be a private home, as I mentioned. Again, where is your home? You might live in a residential care facility. The private home may not be yours. You may be in a room or renting a room. In a trailer, you could live in an assisted living facility. Ultimately, the goal is to try to stay in your place of residence as long as you can. And there is sort of course, the final living option that people have, and that's in a skilled nursing facility. So this type of care, with the exception of the skilled nursing facility, can all be provided in your home. Patients are referred for this kind of care for evaluation by a physician. Now, not only is the referral from your physician, the care for the duration is seen by your physician. Your physician has oversight. So it's really directed, and just a little commercial on physicians. If you have not seen your primary care physician lately, I really encourage you to set up that appointment, make that visit, and get connected. If you've never seen your primary care physician, or you don't even know who it is, you need to set up an appointment and check in. The reason I say this is so many patients who need one of these 3 types of care, in-home care, home health, palliative, or hospice care, end up in either the emergency room or urgent care, and that is their first introduction into their first entry into healthcare. And you need a primary care physician to oversee your care if it's on home health, palliative, or hospice. And when you're in the hospital or the urgent care, it's not the time to be trying to figure out, well, who is my primary care physician? So again, just a little commercial there from a nurse. Please be sure you're getting connected to who your primary care physician is. Once you're admitted onto one of these types of services, you'll get a team, a care team. They will work with you to develop a personalized care plan that is focused just for you and what you need. What are the goals that you have, and what are the goals of the healthcare physician, the healthcare team? How can we get you better? If it's home health, how can we support you and help you move forward if it's palliative care? And then how can we make you comfortable and again, supported and have peace for the last bit of time that you have, and that's our hospice care. Now, the last bullet point here, grief and bereavement care for 13 months, that is for the hospice families. So part of every care term for hospice patients is once their loved one passes, there is an additional year, 13 months of support that is provided to the families as they go through their grieving process. So home health. Home health is short term. It's designed to manage a skilled medical need. So what is short term? That really, honestly, it could be a week, it could be a month, it could be a year. I know a year doesn't sound short term, but if you are a person who is homebound or needs care, and for example, maybe you have a catheter or something that's going on, or long-term infusion, something like that, it could go on for a while. But the primary goal really of home health is to get the patient back to their prior level of functioning. So some of you on this call may have had home health in the past. You may have had this experience. Maybe you had knee surgery and you couldn't get to physical therapy. So a physical therapist came to your home to help. Or maybe you had an exacerbation of your diabetes or your COPD, and your physician, either your primary physician or the hospital, said, okay, you need a little more support in home. So that's what home health is. It is managed by a team. I listed here all the members of the team. You won't necessarily see all of these members. It's whatever you need. Remember, this is a personalized plan for you while you're in your home. And it says there 24/7 nurse on call. Just to let you know, home care, home health is not emergency services. So it is certainly available. You could be in the middle of the night and say, my IV pump is beeping, and a nurse will come out. But it's whatever's going on, we're there to help. But we don't move in. Home health nurses and the team doesn't move into the house, but they are available for support 24/7. And again, the primary goal is teaching. Now, teaching will occur with your loved one, your caregiver, or yourself. It's about teaching you how to do and manage your wound care, for example, or your IV, or I mentioned physical therapist. Physical therapist is going to come and show you exercises that are really important. You're going to need to do that. And your team, your own personal team of support, your family, friends, they will be the ones that are there on the day-to-day 24/7 helping you achieve those goals. Palliative care. So palliative care, again, I mentioned that as a newer term, a newer phrase. It used to, back in the day, refer to hospice care, but there's this subset of patients now that are sort of in between. They are patients who aren't quite ready or appropriate for hospice, but they are struggling with symptoms and stress of a serious illness. This care also is short-term. And again, visit frequency for a palliative patient is very similar to home health. Your care team might be a little different. There's additional care team members in palliative care. You'll see up here, for example, chaplain services or volunteer services available to help you. Music therapy, pet therapy, those sorts of things. Again, support for you as you and your family are navigating through your illness and what really are your goals of care. Do you want aggressive care? Do you want treatment? Or are you ready to move into hospice? So again, palliative care is another type of in-home care referred by a physician and oversight by a physician. So these all require doctor's orders. So before I jump into a little bit more detail about hospice, I just want to talk a little bit more about who's eligible for home health and palliative care. So they're very similar. Both must be under the supervision of a physician, as I mentioned. They require services of a professional, or what's defined as skilled care. There has to be something that is being done or taught. It can't really be just to check in. and make sure things are going okay. There is some skilled need that is occurring. And key to both home health and palliative is homebound status. So what does that even mean? To be considered homebound, you must be somebody who requires assistance of a device or somebody else in order to leave your home. It is what's called a taxing effort to leave your home. You might go out, you have to get food. Maybe you got food, you got back, you're exhausted, you're wiped out for the rest of the day or for a couple of days. You can't get out of your home to get the care you need somewhere else. So I use that example of physical therapy. Maybe I had a total hip replacement or a total knee, and I'm going to use physical therapy, but it's too difficult to get to the physical therapy facility. So the physical therapist will come to me. Once I'm stronger and I feel better and I have more mobility, then I'm going to continue on with that therapy, no longer in my home, but now at a physical therapy facility. So that's really sort of what homebound is really all about. And once you are no longer homebound on home health or palliative care, or the skilled need is no longer there, then the patient will be discharged. So I'm going to move on to hospice care, another type of in-home care. And like home health and palliative care, hospice requires a physician's order and physician oversight. Hospice is, here I listed it as a team approach of caring for someone when this pursuit of a cure is no longer realistic. And maybe not just realistic, but maybe it's not desired. Somebody may feel like, I'm tired. I don't want more chemotherapy or radiation or going to the hospital or all the IVs. I'm ready to just rest and let nature take its course. So in order to qualify for hospice care, your physician has to determine that you have a prognosis of 6 months or less to live. And that is assuming your underlying disease follows its natural course. And we know this. Science tells us this, health tells us this. We know basically, depending on the disease, how long the trajectory is for somebody if they're not getting aggressive care. And when I say aggressive care, I mean those things that I just mentioned, like for medicine, chemotherapy, or other interventions, maybe placing of, if you can't eat, placing a tube into your body so that there's a way to get you nutrition. Those sorts of things are not considered sort of natural in the course of somebody's illness. Now, a tricky illness is dementia and Alzheimer's disease. Patients with that prognosis, or excuse me, that diagnosis, are likely going to be on hospice for longer than 6 months. And while the goal of hospice is support and care, unlike home health and palliative care, you don't have to be homebound. You don't have to be discharged when there's no longer what would be considered a skilled care. You're able to stay on the program as long as you meet criteria, and that is you're still progressing, maybe you're getting a little weaker, things are changing a little for you. But the timeline, sometimes patients are on hospice care for very short periods of time, and sometimes they're on for longer, over a year. So it's looked at by the team. I've listed the team here, generally led by the hospice physician. Sometimes your primary care physician wants to be the lead, and that's okay. There's all kinds of supportive team members. Again, I don't think I put it on here, but additional help, like, I mentioned massage therapy, music therapy, whatever we can do to try to help you live your life to the fullest is what hospice is all about. And again, it's a 24/7 service on call, but the hospice nurse will not be moving into your spare room. So you will still have a caregiver, family member, friend, paid caregiver maybe, or paid staff, for example, if you live in a residential care facility, who will be there 24/7, making sure you get the support that you need. And, you know, as a note, this is again for people who are ready to be peaceful and comfortable for however long they have. No more calling 911, no more going to the hospital, no aggressive care. Certainly the focus is symptom management. If you have, if it appears as though you have an infection, oh yes, of course, we'll do an antibiotic or, you know, but it's not aggressive IV therapy, for example. You're having discomfort. What about that discomfort? Why are you having that pain? We want to make sure that doesn't happen. We work with the physician and get you the medicine that you need or whatever support you need so that you're comfortable and peaceful. So generally that's really what hospice is, but and who's eligible. So just to touch base again, I mentioned you have a prognosis of 6 months or less. If there is deterioration in your condition, I mentioned dementia, you know, that one's a little bit tricky. When is somebody at that landmark of 6 months or less when they have dementia? It's so hard to tell. Move a little quicker than others, but generally speaking, when your dementia patient or loved one can no longer walk without assistance or at all, if they are not able to communicate in a meaningful manner, they're unable to dress themselves or bathe properly. Usually these patients are incontinent. You'll see maybe weight loss. They have maybe refusal to eat or difficulty swallowing. These are all indications that that dementia patient, Alzheimer's patient, may be appropriate for hospice. The bottom line is that what you need to do is, again, as I said, be connected with your primary care physician, because like home health and palliative, hospice requires a referral from a physician. So the physician has to determine if a patient really meets the criteria, and they'll do that and then send the referral over to hospice. It's for people who have exhausted all their aggressive treatment. So hospice isn't the time if it's, yeah, I'd like the support of hospice, but I still have 5 more radiation treatments, or I might be able to qualify for a new trial med, and we're going to try that out. It's once all of those treatment options have been exhausted because they're not an option, or again, like I said before, maybe you're just tired, or the patient says, I'm just tired of all of this. I'm ready to go. I'm ready to let things happen. Now, I will tell you, some patients are discharged to hospice. They don't all pass away. So again, this is followed by a care team led by a physician. And if a patient no longer meets criteria, we see this a lot of times with stroke patients. They have had maybe a stroke and are very debilitated and meet all the criteria, but then all of a sudden they kind of rev up and start to do better and improve. And if that's the case, then the team will decide what the next level of care that would be appropriate for that person would be, but it may not be hospice. So sometimes patients are discharged. And I say that because oftentimes hospice is brought in too late or at the last minute. The earlier you can access these services, the better it can be, the more time you have to come to terms, to experience togetherness. I know that sounds a little, flu, but it's so true. Having a hospice team come in and support someone who is actively dying or only has a few days to live is so incredibly stressful and difficult for everyone, the patient and the whole family. So being aware of where you are in your disease and what you want for yourself and your family members is very important. And a little side commercial I will say right here is be sure you have all filled out a durable power of attorney for healthcare and made your wishes known. Letting people know what you want for yourself is incredibly important and making sure you've named the person who will make the decisions for you the way you want them to be made when you can no longer make them. That is critically important, because it's so hard for everyone to have a patient who may be suffering or in a particular state, and nobody really knows, quote, what they would want. And there's dissension. Mom wouldn't want this. Yes, she would. It's so hard for your care team, for the hospital care team, for anybody who's trying to make the right decisions. So again, a little commercial here. Make your wishes known. And as a sidebar, I have my website, gives you access, and there's some information at the end. You can go onto Livingston's website and ask for a free 5 wishes booklet. And also we have a recording on the website too that can walk you through that document. It's an opportunity for people to say, here's what I want, here's who I want to make my decisions, this is what I want this to look like. And it's a legal document, and it's really important. So sorry if I got off on that, but so many times we see this, and that's why people are not accessing the care they can get, like hospice, for example, until the very, very end. So don't let that be you. Okay, now let's move on to the most common type of in-home care, and that is private duty caregiving. So unlike home health, palliative, and hospice care, this type of care does not require a physician's order or oversight. So private duty caregiving is non-medical supportive care for people who need just a little bit of extra, so that they can stay in their home and get the help and assistance that they need. And usually the assistance they need is personal care, or we call that, you may have heard the phrase ADLs. That stands for activities of daily living, and that's what's here: bathing, dressing, transfers, mobility assistance, toileting assistance. At some point, most will need a little bit of help with these areas. Not all, of course, but remember that number. I think 70% of us will at some point. It may be reminders on what to exercise, what to do. Medication is an interesting one. There's actually products on the market that assist with these sorts of things. You can set up for your loved one medication in a pill reminder. It actually sets an alarm and opens up a little slot, and the pills for that time of day and day are right there ready to go. But not everybody has this sort of technology or these sorts of devices. So, you may end up needing private duty caregiving to help you with these sorts of things. And then everyday needs, getting rides around. It's more difficult maybe to drive. Maybe your license has been taken away. You need a ride to the physician's office, to the pharmacy, grocery shopping, maybe a little assistance with light housekeeping. All of these things are more difficult as we get older. And accessing what we call a private duty caregiver to help with these sorts of things is very, very common. What's interesting is that 80% of this type of care is provided by unpaid caregivers, 2/3 of which are women. I don't know that that's a surprising statistic to you. Women tend to be the caregivers in homes, and we see that that's true. Statistics tell us that that is true. And usually these caregivers are family members. So there are probably a large number of you on this call today who are actually a caregiver, and maybe you didn't realize you were doing private duty caregiving, but guess what? You are. On average, once somebody needs care, it's about 20 hours a week of this sort of care. So it's no small feat, and it is really hard. The sandwich generation of us are caring for our children and for our parents, because again, we are living longer. Our parents are living longer. The longer we live, it ends up more care that we need. So who pays for all of this? How can I afford this? Well, let's look at home health first. Home health and palliative care. If you have straight Medicare, this kind of care and service is covered at 100%. Remember, there's the other criteria about needing a physician's order, a skilled need, being homebound. All of those things are still in play, but Medicare will cover that at 100%. Medi-Cal, or in our county, we call that Gold Coast, is also 100% covered. Now, there's a little caveat there because we may have a small share of cost depending on your coverage. So that individual, it could be 100%. You could have a small share of cost or copay related to that. And then finally, private insurance. So I put most private insurance, and most do have home health coverage. But it's really important for you to know your policy and understand what coverage you do have. So for example, when I mentioned it's important to connect with your primary care physician and know who that is before something happens, before you need them, it's also really important to educate yourself and be prepared and understand your insurance policy before it has to kick in, because sometimes there's limits. So for home care, in some, it's rare, but in some, you can only have so many visits per year allowed. You might have a copay that you have to pay for every visit until your out-of-pocket has been met. And what is your out-of-pocket? So these are all things to be sure that you check on. Now, if your doctor has ordered home health for you, or palliative care, it is the home care agency's responsibility to make sure you know what your financial responsibility might be. So before care can start, they are expected to tell you about any financial responsibility, actually regardless of whether it's Medicare, Medi-Cal, or private insurance. So you will know upfront if you do have a copay or a share of cost. That is all part of the admission process into home health. Okay, so let's pop over to hospice. Hospice, like home health, Medicare covers this at 100%. Same with Medi-Cal or Gold Coast, it's 100% covered. There still could be a share of cost. Again, this just depends on what level that you are at. And then private insurance generally has coverage. Rarely, I think, golly, I've been doing this for 23 years. I feel like I only recall one time when someone's insurance did not have a hospice benefit. And that law actually, that was years ago, and that law actually changed. So now it's required that every insurance policy has a hospice benefit to it. The caveat is it doesn't say what that means. It doesn't say it cannot be limited. So again, educate yourself, understand what kind of coverage that you have. It's rare, but there could be a piece about your access to hospice care if you have private insurance. But really, most people who use hospice are older, and they have signed up for a Medicare, usually a managed Medicare or Medicare Advantage plan like SCAN or WellCare, Kaiser United, all of those MA plans, which are very, very popular and certainly rising in utilization. If you sign up for hospice, you choose hospice as your care, your insurance goes back to straight Medicare. It reverts back to Medicare, which means then you're covered at 100%. So, again, that's the care that people that come into your home, the equipment you might need, like a bed or oxygen, all the medication that you need, all of that is covered at 100%. Okay, so let's now take a peek at private duty. Private duty caregiving, again, is the most common type of care and really utilized for the longest period of time. Medicare does not cover this type of care. That is not a Medicare benefit. Now, Medi-Cal may cover it. There are some hours that can be provided through something called in-home support services. And there's different levels of reimbursement for in-home support services, depending if you have a medical need, like wound care, for example, like your caregiver may be doing something in the medical world for you versus just activities of daily living. Usually the in-home support worker is a family member. We don't have a lot of in-home support service workers available in our county. And most of the time, we find patients who need this sort of care, a family member quits their job or decreases the hours of their job so they can care for their loved one. Well, if your loved one has Gold Coast or Medi-Cal, there may be some reimbursement for you. So that's a really important thing to understand and to investigate. Veterans aid and attendance. This is additional funds that can be paid to you for care and assistance for a veteran, but also for their spouse. So if you're a veteran or your spouse was a veteran and you went to va.org, or excuse me, va.gov, there's an application, you can look into it, see if you qualify. But here's another, I guess my presentation is full of commercials. So here's another commercial to go back and watch all those VC AAA brain health and wellness webinars, because in the April presentation, which was presented elder senior care and insurance issues, legal issues, it was presented by attorney Chris Young. He actually mentions this aid and attendance in his presentation. So again, if you're a veteran or you have a veteran who's your spouse, there may be funds to help pay for some of the care that you need, some of this private duty care that you may need. And finally, there's private pay. So there's a couple of ways that private pay works. You can access private duty through long-term care insurance. Oh, sorry, I totally bypassed long-term care insurance. Oh my gosh, I'm so sorry, guys. Let me jump back to that because that one is huge. So forgive me. So I'll circle back above long-term care insurance. So long-term care insurance is interesting. You pay for the premiums, you buy this. Usually the younger you are, when you purchase this insurance, the lower your premiums are going to be. And again, like anything, understand your insurance coverage. Carriers usually will only work with licensed agencies for this kind of care, not private individuals. So it's really important to understand what you're buying. There could be limits. A big one to really read the fine print on long-term care insurance for private duty caregiving is what's called a waiting period. So depending on your coverage, you may have a waiting period before you actually get the assistance that you need. I have seen this time and time again. People will have the long-term care insurance. They're, quote, saving it up until they really need it. And then when they really need it, it turns out there's a waiting period for a various lengths of time. And by the time the waiting period is over, they don't need the care any longer. So really, it's important to understand what you're buying and what your coverage is. The California Department of Aging publishes a booklet. It's called Taking Care of Tomorrow. And it has a lot of detail about coverage and long-term care insurance. And it's actually mandated if an agent is trying to sell you long-term care insurance, they have to give you this booklet. But you can get it before you're buying long-term care insurance through something called HICAP. And I have this information on the resource page for you. HICAP stands for Health Insurance and Advocacy Program. They provide free confidential one-on-one counseling and education on insurance matters, Medicare, other related issues. And it's, again, free and confidential. I put the contact information on the resource page, so you will have that if that's something that you need. So long-term care insurance is a great alternative. Many more people have this coverage. But again, just important to know what you're buying and what the rules are. Now I'll jump back to private pay. So private pay is the most common way to pay for private duty caregiving. And I'm taking a lot of time on this sector because, again, it is the most common and the most easily accessible care because it doesn't require that physician order or oversight. So in private pay, the common ways to pay for it are through a caregiving agency. Livingston, my company, has such an agency. If you are hiring a caregiver through an agency, those caregivers you can be assured they're vetted, they've had a background check, they're insured. All the caregivers that work for any licensed agency have to be registered with the state. If a caregiver calls out, usually the agency will be able to send you a substitute. So those are all really positive things to consider. But very common is just basically private hire. That's usually word of mouth. That might be, someone who had a caregiver, a friend, a neighbor, someone who knows someone. I would just say buyer beware, because in this kind of relationship, you may not have all those other backups like insurance, background checks, those sorts of things. There are some agencies who act like matchmakers, sort of. There's one called care.com, and they'll connect you with a caregiver, but in the end, you're the employer and they're your employee. So aware of what you're purchasing. Now, private hire, that's cheaper. On average, it's about $18 to $22 an hour. That's likely what you'll pay. If you go through a caregiving agency, you're likely to pay more like $25 to $35 an hour. But you do get some other assurances that you don't necessarily get if you just privately hire. And the kind of care you can get is hourly. It might be a few hours, a few days a week. It may be just once a week for assistance with some of your errands, for example. But again, it could be up to 24 hours a day, 7 days a week. Some agencies have care packages, like a bath package. It seems like, whoa, this is overwhelming. I just need someone to help me, a few times a week clean up. Well, there's bath packages. Or, mom's great once she gets going, but gosh, getting her up, dressed, having some breakfast, that's the challenging part of our day. Well, sometimes agencies will have a wake-up package, or vice versa, a tuck-in package, where, a caregiver comes in the evening time, helps make dinner, and then nighttime routines and activities, getting ready for bed and getting tucked in. So there's all kinds of different levels. It's up to you to work with your caregiver or your caregiving agency to determine what exactly that you need. But again, in all of this, the primary goal of private duty is to keep people in their homes, to allow individuals to age in place as long as they can. So here are some of those resources that I mentioned, primarily, the rock stars of the county, the VC AAA. When all else fails and you don't know, you pick up the phone, you call them, and they're amazing on helping direct you. The HICAP, I mentioned that earlier. And then below are websites that you can access, links to all of these agencies. Aging and Disability Resource Center. And then there's something called an Elder Care Locator. It's a nationwide service that can connect you with caregivers in your area and other senior services. So that was a lot of information. I have my contact information. My name is Tree Pavon, and our phone number here for my agency is listed, as well as info@lmvna.org. So if you have a question about anything that I said or presented, or maybe something I didn't say or present, and you need a little guidance, please feel free to reach out. I would be absolutely happy to get you connected to the right resources.
Sri, thank you so much. You are a wealth of information. You just, and I think those who aren't clear, know it all. You just gave an amazing overview. There is one question that came into the queue, and if anyone would like to ask a question, feel free to put it in the chat or also just on the question and answer. One of the questions is, do private care arrangements require workers' comp insurance for the employer to pay or provide?
If you're working with a caregiver through a licensed agency, yes. If you are hiring on your own, it's a risk that you take. If you've privately hired somebody to come into your home and help care for you and something happens to them, that's a tricky one. Your homeowner's insurance may help cover anything related to that, but it isn't considered workman's comp. So any licensed agency will have that support for their caregivers that work for them. So that's another sort of piece that you just have to really think about. So it's a great question as you're deciding where you want to go for that caregiving.
That's a great question. Let's see. I hope we answered that, Kevin. He put that through. Feel free, if anyone has any other questions, feel free to put them in the chat. But I have one in particular for you, just because of the hospital now with the COVID situation. Like, how are you handling COVID with your staff and like going into these homes? And what do you still have protocols like to not take patients, or tell us a little bit about that?
Wow, Maureen, that is a great sort of question. You are on topic. COVID, boy, don't get me started on COVID. So interestingly enough, July 15th, the COVID health emergency has been extended through October 14th. It was initially declared an emergency on January, I think 27th of 2020. So this has been an ongoing issue and absolutely a concern for care for patients and clients in their own homes. So I can speak to what Livingston is doing as a home care organization. I can't speak to necessarily what other organizations are doing, but I think it's probably similar. And we are taking care of patients who have COVID in their homes, or if they're living in a home with somebody who has COVID, we will still come in and give you the care that you need. The protection there is multi-layers. So first of all, you'll have your caregiver or whoever's coming in is going to ask you questions before they come in through your home, so they know what to wear. Are you exposed? Are you having symptoms? That sort of a thing. But every caregiver, home health, palliative, or hospice clinician, licensed clinician who enters a home into a COVID environment will be wearing what's called PPE, or personal protective equipment. It is kind of what you may have seen, on the news when they are showing healthcare workers, not as elaborate as what the ventilators and the different full suits that the hospital staff are wearing, but they will have what's called an N95 or fit tested mask, and that's to protect you as well as to protect you, the patient, as well as to protect the caregiver. They'll have a face shield on, a gown, gloves, all the extra protection that they can have, so they can still provide your hands-on care, but also not leave the house with a COVID souvenir, if you will. Now, the interesting piece to this, though, that has happened with COVID is that caregiving, that private duty piece. And most private duty organizations, ours included, are not entering a known COVID environment. The reason for that is because generally when a home health, palliative, or hospice clinician goes to the home, that's a short period of time, an hour. They're there, maybe a little longer, a little less. They come and go, maybe a couple times a week. It's not constant. When you have a private duty caregiver, with the exception of those packages I mentioned, generally they're there for hours, 8 hours, 12 hours, longer periods of time. So the chance of becoming infected when you're spending that kind of time and that kind of impersonal space with somebody who's infected, the likelihood of becoming infected yourself is very high. So in those instances, for us, again, I can speak for Livingston, when the patient has COVID, until they have run through the course, the necessary timeline of however many days that is, we would not have a private caregiver in the home. But it's a great question, and COVID has really turned things on their ear here with that. I think you're
I
muted.
have one more question that came in. Can you provide a link to access your slides? And maybe Ben, are you able to just pop that into the chat? Or you can, yeah, thank you, Ben. And Tree, you have your email address. Is that the best way to reach if people have further questions, or do you have an email address we can just pop in there if they want to reach you?
Yeah, what's posted up here, Maureen, is really the best way, because I want to make sure you get connected in a timely manner, and this is manned, this email address, by staff, and so they'll make sure you get connected. If it's to me, then they will make sure that I get the message. Also, this phone number is to my organization. You can just ask for me. My name is Tree. I'm the only one that's here named Tree. Can you believe I'm the only one named Tree at my organization? So I'd love to speak with anybody. Again, you can shoot you'll have my slides. Thank you for sharing those. And again, you can send any kind of question that you have to this info@lmva.org, and we will get back to you. I or one of my team members.
Great. Oh, I forget that I had that blocked on my screen. Yes. Well, great. Well, Tree, thank you so much. If anyone has any last minute questions, I don't see any coming through, but we're really thankful to all of you who could be on with us today. And next month, I forget the topic. I had it open here. Maybe Ben, what's the next month for you to join us? Yes.
It's caregiving resources. I'm all over it. You have caregiving resources, Alzheimer's disease in September, financial services in October, November, neurological, and finishing off the year with the Ventura County Memory Cafe. So amazing, amazing opportunities for everybody in the county.
Yeah, and just for you who are on, just send this and forward it to anyone who you need, and you can listen to these. Go on the VC AAA website, and all of these can be listened to again. You can forward it to your friends. So we're really thankful. Tree, thank you for all the work you put into this today, and we're just so grateful for your services. Your team is amazing out in the field. So thank you. Thank you to VC AAA. I'm Maureen with Community Memorial Health Systems, and I'm excited to be a part of the VC AAA board, and really excited about what we're trying to do to help our county understand services for the elderly and aging, and how we all need to really work together, because it's a big Tree. At the beginning, you talked all about the statistics of caregivers and the statistics of aging, and we're all going to be aging and needing more caregivers because the population is so big. So we are all in this together. So thank you, Tree, and thank you, Ben, and to the rest of the team. And I think that's it.
Thank you, Maureen.